old wine in new bottle. We will try to focus on the new things rather than old things which are already existing and we know. So acute heart failure management or acute heart failure is an entire scenario. We cannot focus everything. So we will try to focus some particular points and the rest of the things we will have a glimpse of. So today's timeline will be, first will be definition, that is foundational understanding. Then some pharmacological insights, approach to acute decompensated heart failure, lesson learned from the existing pharmacotherapies. Then we will talk about some technological advancement and that is the newer things. And then GDMT and outcomes, that is again we know about GDMT and outcomes. So firstly about definition and spectrum of acute decompensated heart failure. It is fundamentally a state of worsening congestion and impaired forward cardiac output or combination of both. So definition says a sudden severe worsening of heart failure symptoms like extreme shortness of breath, fatigue and swelling caused by heart's inability to pump enough blood leading to fluid buildup, that is congestion, that requires urgent medical care, often hospitalized. So 2 points are very important. First is congestion. So all theory, all pathophysiology, all management revolves around congestion and reduced cardiac output. The syndrome often occurs across the spectrum of reduce or mildly reduce and preserve ejection fraction also. That also we will discuss in next couple of slides.
So આ symptom માં તો de novo heart failure નો define નથી થતો.
De novo થશે. I'll come to that.
Definition માં નો છે.
Definition માં નથી. પણ again it's a congestion.
ADHF જ કહ્યું છે ને.
હા ADHF. But again it's a de novo heart failure is a congestion, congestive symptoms. De novo is it's a substrate that I'll come into maybe after 2-3 slides I'll come about a substrate.
Definition is incomplete.
Yes. See, it's a very long definition, so everyone defines in a different way. So heart failure is a chronic condition interspersed with acute decompensated episodes. So if we look at this, so this is a heart failure spectrum. And many times patients will have acute decompensated phases which requires hospitalization at times. And then eventually there is chronic gradual decline in cardiac function over the period of time.
Typical Indian patient of
And India witnesses a huge heart failure hospitalization burden. Hospital readmission at 1 year is as high as 30.2%. This is Indian data, quite old, 2017. There are no newer data after this. And 1 out of every 3 patients readmitted at least once in a year. And the important point to note here is, irrespective of ejection fraction, the readmission rates are similar. Irrespective of the gender, readmission rates are similar. It's a very high readmission rates. And the problem is that with every new readmission, the longevity reduces. Like after first hospitalization, median survival time is 2.5 to 3 years. After 4th hospitalization, it drastically reduces to 0.5. So with every readmission, the survival rate reduces.
Your data is with the GDMT or without it?
No, this is even with GDMT, but this is older data, 2007, where this Vimada was not introduced.
And this is what I am explaining, because we treat the patient and we know what our readmission is.
Yes.
Those who are regularly,
No, this is acute decompensated, like patient who requires inotropic support or some decongestion.
those patients who follow up with us and they with good follow up, I don't think it's a
Chronic
readmission.
stable heart failure patients. So chronic stable will have not steep decline. They will have a plateau, slow, gradual decline in the survival. So if patient is in compensated phase, yes, longevity is good. Acute decompensated episode reduces longevity. But after introduction of ARNI, this chart was still changed. Unfortunately, I could not find that chart after the introduction of ARNI. So when we look at heart failure spectrum, multiple ways to define heart failure spectrum. ACC stage is also like ABCD, then NYHA functional class 1 to 4, intermax pattern. If we look at clinically, then pre-cardiogenic shock, cardiogenic shock and refractory cardiogenic shock. So mainly we will focus today on pre-cardiogenic shock part. So let's move on to the pathophysiology. So pathophysiologically, heart failure can occur in any kind of heart. So the basic substrate would be either normal cardiac structure, or it could be structurally abnormal heart, like structural heart disease in form of either restrictive cardiomyopathy, dilated cardiomyopathy, or it could be a chronic heart failure. So substrate could be anything from normal to dilated heart. On this substrate, there are certain triggers like hypertension, acute coronary syndrome, arrhythmias, some cardiac infection like myocarditis, renal dysfunction, or non-adherence to medication, in particular in our sector. This leads to multiple amplifying mechanisms. Like in myocardial, it leads to decreased cardiac output, it leads to diastolic dysfunction, it leads to myocyte injury in form of acute coronary syndrome, it leads to ventricular interdependence, that also I will discuss in a few slides. Tachycardia also. Beyond heart, the kidney is the most important organ which is getting involved in acute decompensated heart failure. So renal involvement lead to sodium and volume retention, acute kidney injury, renin-angiotensin system activation. Vascular involvement leads to endothelial dysfunction, increased arterial stiffness, vasoconstriction, and neurohormonal imbalances like RAS and sympathetic nervous system activation. And this everything leads to congestion and organ dysfunction.
So regarding the trigger, when you put uncontrolled diabetes,
Yes. Uncontrolled diabetes over a period of time leads to renal dysfunction. And
first time I will tell you, I have seen young female who had presented with acute heart failure first time in her life, and her diabetes was fine. First time.
So that is maybe decay part of.
No, it was not decay.
Not decay, only.
Young woman presenting with acute heart failure. Subsequently, everything was normal. I controlled the diabetes.
Okay.
The rest of the time, she had no heart failure at all.
Okay.
Possible. Without uncontrolled
Yes.
diabetes,
It's not there, but yes, it is possible.
પણ ટ્રાયગર્સની અંદર આટલા સેટઅપની અંદર અનસુપરવાઇઝ IV fluid transfusion that is also very
Very
common.
Very
common.
in very patient
Very
IV fluid and the patient will end up with heart failure.
If you try to
Very
find out, it is very common.
Diabetic cardiomyopathy presenting as acute decompensation is very rare.
Very rare, but yes, it is possible.
A patient to HbA1c will also sir 500 वाला.
Okay, the center part of all this pathophysiological mechanism is congestion. We have to treat congestion by any means to tide over the acute heart failure crisis. So congestion could be of two types. It could be clinical congestion that we know by the means of dyspnea, RELS, basal crepitation or raised GVT. And this clinical congestion is generally preceded by hemodynamic congestion. And this hemodynamic congestion is either picked up on echo or invasive studies like raised ventricular diastolic pressure. So we need to control this. We need to find hemodynamic congestion and we need to treat it before the time. So how hemodynamic congestion worsens the heart failure patients? Hemodynamic congestion increases wall stress of myocardium leading to myocyte loss, then fibrosis. Hemodynamic congestion leads to increased renin level, leading to RAS activation and sympathetic nervous system activation, that leads to vasoconstriction further and leads to worsening of the situation. It increases diastolic filling pressure, leading to decreased coronary perfusion because coronaries are getting filled during the diastole, and it worsens ischemia if at all there is any underlying ischemia. And it also leads to spherical remodeling of heart, which leads to dilatation of mitral annulus, and mitral regurgitation leads to pulmonary ED. So this is the basic pathophysiology. If we dig deeper into this, the pathophysiology is very much interconnected, where acute heart failure further decompensates kidney, leads to acute kidney injury. It's a vicious cycle. Once kidney is getting involved, that kidney will again leads to acute heart failure, and this is a vicious cycle which will continue. So decreased cardiac output leads to decreased perfusion to vital organs like kidney, that leads to endocrine damage, acute kidney injury. There is increased venous pressure leading to renal injury, increased sympathetic activity, and there are multiple some enzymes, inflammatory markers are also getting involved like cytokine storm, which work further worsens the heart failure. So the vicious cycle of heart failure starts with congestion. Congestion leads to increased wall stress, which leads to neurohormonal activation, which again decreases cardiac output, which again worsens congestion. So at some point, either you have to increase cardiac output or reduce the congestion. Now, increasing cardiac output by way of medication, if we forget ARNI, it's not possible. So we need to target congestion first. Cardiac output either by device or by introduction of ARNI.
Neurohormonal activation will increase cardiac output or decrease cardiac?
No, it will decrease cardiac output. Neurohormonal is a sympathetic nervous system and RAS activation that will lead to vasoconstriction. Again, it's an afterload increased condition. So that will reduce your cardiac output.
Very complex. Directly cardiac output decrease થાય એવું ના હોય કારણ કે બોડીનો નેચરલ મિકેનિઝમ છે.
Yeah, it's very complex.
Initially it will try to increase the cardiac output.
Yeah, initially it will try to increase by the increase of inotropic action, but later on the substrate, they depend on
Inotropic
substrate.
as well as chronotropic both.
Yes. So if the substrate is dilated cardiomyopathy, your substrate is either structural heart disease, that to certain extent it can increase inotropic, but beyond that it cannot increase inotropic. So that again everything based on what is the basic substrate.
Yeah, but acutely
And secondly, what further mechanisms of this cytokine, we don't know exactly what this NGAL is going to do, what this LPAP is going to do. At certain extent, they are also fibrotic agents. So over a long period of time, this
So that is not long. If your neurohormonal
Yes,
axis stays activated for longer time, it is
Yes.
the culprit.
yes, it is a culprit.
But
It is
initially,
going to lead
if
to
we are
fibrosis.
discussing in terms of acute, then it is the thing which
Acute
will
is-
survive patient.
Yes, acute is either as increased vasoconstriction, congestion, and decreased cardiac output. Acute is these three things. But as we know that the chronic heart failure has multiple episodes of acute heart failure. So at the end of the line, this acute heart failure cytokine storm is also to certain extent it is in.
Just when there is no neurohormonal activation, patient will die immediately.
Yes. Unfortunately, we could not control that cytokine storm as such. So the clinical spectrum is very simple. It could be isolated congestion in terms of fluid retention. What sir has said that that lady had either fluid retention and that was in isolated congestion phase, treated very early and treated easily. This isolated congestion can be in form of peripheral edema or pulmonary edema. Followed by, in moderate acute decompensated heart failure, there could be volume overload with reduced cardiac output and certain end organ dysfunctions like renal dysfunction. And followed by the severe part, that is a cardiogenic shock. So most important to know is that there are
Before that, say, I would like to see there are spectrum of acute decompensated heart failure. And one hand, still patient saturation maintained, and that patient do not require any bypass of.
that part I don't. There is that.
When there are another spectrum, see within half an hour, this patient arrived and within half an hour, patient rapidly progresses and that patient goes into ventilator, not bypass, ventilator. So where is the pathogenic, what kind of pathogenic mechanism which makes some of the patient, mildly decompensated and some patients who are highly decompensated.
That depends on sympathetic nervous system activation. If it is highly active, patient will rapidly deteriorate. Very rapidly. That is what we were discussing about. Sympathetic nervous system rapidly deteriorates. So to certain extent, and on top of that we will give noradrenaline again, that is the sympathetic nervous system overactivation. So that deteriorates. But these are the four phenotypes. What you say, that is very right. The warm and dry part, patients who have warm peripheries, patients who are generally not very much trepidation, they can be treated on OPD basis also. So these are four phenotypes based on cardiac output, cardiac index, and pulmonary capillary wedge pressure. If cardiac index is normal, means patient's cardiac output is mildly reduced or well preserved, and patient is dry, so that is goes into the territory of warm and dry, or Forrester class 1, mortality here is less than 3%.
That instead of that cytokine storm, which is very very rapid and very fast, cytokine storm. It is not only
Not only sympathetic nervous, it's multiple.
the cytokine storm which occurs and you are not able to control.
Unfortunately, medicine to target that side of the immune response. Followed by second class, that is warm and wet. That is Forrester class 2, where mortality is nearly 9%. Still it is controllable mortality. Here peripheries are warm. Patient is having some signs of congestion in form of basal crepitation. That can also be treated either with injectable drug. Patient generally does not require BiPAP or inotropic support. The major problem starts here, class 3 and class 4. That is cold patients whose cardiac output is less. Either maybe patient is dry or patient is wet. If patient is cold and wet, mortality is maximum. So next slide, couple of slides.
If you convert this into the clinical side,
Yeah. So
how will you the first pregnant patient is lying down
lying down
and taking.
taking. Slide.
Second type is the patient is orthopneic.
Yes.
Third and fourth patient
The
not
second generally
orthopneic.
patient will complain of PND, intermittent PND.
Yes. And third and fourth,
Start-
not only patient is orthopneic and PND, one quite restless.
Yes. So
Quite restless.
Third stage will not be a
Yeah, so it's like this. NYHA class 1, 2, 3, 4. And it more or less coincides with this also. Here patient will be symptomatic at rest. Patient won't be able to even speak a single sentence in a single
Restless. Because the hypoxia is so prevalent, hypoxia is so marked, patient is very restless. So from the distance you can make out a stage 4 itself.
And here, third stage, patient will have cold peripheries, maybe or may not be congested. Maybe some early congestion is there, but generally patient remains dry. So we will see how to approach this one by one. So treatment
So in
strategies.
which clinical condition you will have stage class 3?
It's only dilated cardiomyopathy or reduced ejection fraction in early part of failure, where congestion is not yet setting. Hemodynamic congestion is there, clinical congestion is not setting.
So it has to be the patient who is having right heart sided heart failure as well.
Okay.
That should be one thing. Second thing, he must be on some incomplete treatment.
Incomplete right.
Right.
Like
So
low
there
dose
is some lung
diabetes,
congestion is already there, but right side is now not supporting. So left side is now started failing and cold extremity started becoming, but it is on the way to going with the stage 4.
So this is still in compensated by slightly.
Slight
It will
compensation.
rapidly deteriorate if there is any trigger. So any patient who is having suspected acute decompensated heart failure, first check whether there is cardiogenic shock or not. If there is cardiogenic shock, like in terms of low blood pressure, cold peripheries, patient will require circulatory support in terms of either pharmacological or mechanical. If patient is having respiratory failure, patient will require ventilatory support in terms of nasal oxygen, mask, non-invasive ventilator or invasive ventilator. And then identify the acute etiology, that is denominated by the mnemonic charm. Either check for coronary syndrome if there is any, hypertension, arrhythmias, clinical cause and pulmonary embolism. When we are talking about coronary syndrome, unfortunately our cardiac markers, troponin is not going to help much, because troponin will get elevated with any kind of wall stress. So any decompensated or compensated heart failure, troponin is going to be raised. So what will help us? The detection of new regional wall motion abnormality on echo, detection of some ECG changes, so that will help us rather than troponin. Or else, troponin, not single, if it is rising trend, troponin, repeat troponin after 3 hours, if it is rising, if it is doubling, then it can be again secondary to coronary syndrome. Hypertension we can all detect, arrhythmias can be detected on ECG, mechanical causes can be detected by echo, and pulmonary embolism again can be detected either by clinical suspicion and followed by CT.
Pulmonary embolism can lead to stage that class 3.
Class. So, if we go further deeper into this, any patient with acute decompensated heart failure, bedside assessment for hemodynamic profiling first. That will tell us about presence of congestion or not. If there is presence of congestion, it means the patient is wet. Check for adequate peripheral perfusion. That will again determine our first type. If peripheral perfusion is present, then patient is wet but warm. Then check for presence of hypertension. If there is hypertension, this is vascular type of fluid redistribution where hypertension predominates. The treatment part is mainly vasodilators followed by dilators. Generally we need to be both in such kind of patients. If it's a cardiac type of fluid redistribution, like central congestion is more rather than peripheral and blood pressure is normal, here the main part of treatment will be diuretics followed by vasodilators. If at all it is refractory, we may need ultrafiltration, that is hemodialysis. So this is our first part, wet and warm. If patient is having congestion, peripheral perfusion is not adequate, this goes into the subset of wet and cold. If your systolic peak is less than 90, the primary treatment remains inotropic agent, vasopressor agent in refractory case, diuretic after correction of the perfusion, and then mechanical circulatory support also sometimes it is required. If systolic blood pressure is maintained, again the major part will be vasodilators followed by diuretics, and consider inotropics in refractory cases. So that is our wet part. If there is no congestion, patient is generally dry, peripheral perfusion is present, this is very easy category, dry and warm, compensated state, consider oral therapies, you can send safely patient to. If patient is dry but cold, consider hypovolemia first or hypoperfusion first, give fluid challenge. If fluid challenge is not adequate, inotropics are required. So only in this dry and warm patient, you can treat on OPD basis, rest everything needs admission either in wards or in ICU. So that brings us to the separate pharmacological agents. Diuretics first, because this is the most common and foremost important drug in the treatment of acute decompensated heart failure. So here I talk about some boring trials. So this is first trial, a well-known trial, dose trial, which was published in 2011. In this trial compared low dose diuretic versus high dose diuretic and bolus diuretic versus continuous diuretic. So this is bolus versus continuous, low dose versus high dose. Unfortunately, the p-values are not at all significant in both the groups. In terms of change in creatinine level, in terms of global VAS score, it also remains same. However, secondary endpoint showed high dose is useful in terms of net fluid loss, net weight loss, net weight loss, everything was useful high dose. And again, continuous dose was also useful in terms of net weight loss, net fluid loss, and decreasing length of stay and relief of symptoms. So ideally, based on this trial, the recommendation is to use high dose of diuretics and continuous intravenous infusions in early phase of acute decompensated heart. Beyond loop diuretics.
So what is the main mechanism of action that within minutes your loop diuretics will have symptoms improval?
Within minutes, that is pulmonary vasodilatation, followed by dialysis.
So dilatation, it also dilatation in early hours, right?
Within minutes is the pulmonary vasodilatation. Then comes the tolvaptan, which was again very famous of lately. But in tactics trial, which was published in 2007 and Aquamarine in 2016, the primary endpoint of responder at 24 hours did not show any significant changes. P-values not significant. In Aquamarine trial also, the primary endpoints are not met. P-values were not significant. Edema reduction was there, but it was not significant. Pulmonary congestion reduction, again it was not significant. Orthopnea reduction, it was not significant. So when it is supposed to be used, it is useful in patients who are fluid overload and have hyponatremia. That are the only case where tolvaptan is useful, not otherwise recommended as a routine therapy. Acetazolamide, another diuretic. It generally works prior to the site of action of loop diuretics and it may improve diuretic efficiency. That was the basic funda. Edward trial in 2022. Primary endpoint of placebo versus acetazolamide. Risk ratio reduction, p-values significant. Placebo versus acetazolamide, again p-values are significant. Total 519 patients, but the death from any cause does not show any change. So it does not have any mortality benefit, but appropriate decongestion achieved at 3 days and at the discharge was significantly changed with acetazolamide. So again, it can be used as an adjunctive therapy, not as a routine therapy.
been to CSL.
There is no head to head.
What one heart failure specialist said, that is, furosemide is more of a aquauric.
Acquired.
Ah.
So water.
It causes water, it doesn't cause much sodium loss.
Yes.
To add the sodium loss, you add acetonamide.
Yes.
So that will enhance the, diuretic effect of the furosemide. So initial 5 days, give IV furosemide along with IV acetonamide, which is not available, so you may use oral for initial 5 days. So that it will enhance the sodium excretion, which is again the root cause of acute decompensated heart failure because of action on the kidney.
Yes.
So that will enhance. So give for initial 5 days, give both the therapy.
Okay. So
That is the heart failure one.
So
From
then you
UK,
guys come to head to head trial is there, like basic and basic.
So there are no head-to-head of
Yeah.
furosemide versus acetylcholine, furosemide versus acetylcholine. No head-to-head.
By anyone is having the experience, I think nobody has used
No.
IV or oral
In
acid.
residency time we use in some patients, but
Acute setup
No.
of
Secondly, this is with the placebo actually. you are showing.
yeah, this is
So
with placebo.
We have to compare with the diabetic which we use routinely.
So as sir said, this will boost the
Yeah.
diuretic effect. It
Yeah.
does not as a primary diabetes. Then beyond this, there are certain mechanisms which lead to diuretic resistance. I am not going to detail, but there are multiple mechanisms like reduced absorption of diuretics, unable to bind to albumin, reduced filtration, proximal sodium reabsorption again in proximal tubules, and distal sodium reabsorption also plays a role. Coming to the second part, beyond diuretics, vasodilators. I will not talk about nitroglycerins because we know that nitroglycerin is good vasodilator and everyone is using this. So beyond nitroglycerin, certain vasodilators are necessitide. It was most used drug in past somewhere in 2013 to 2015, and venous arterial and coronary vasodilators, it increases cardiac output without increasing inotropic effect. So two trials were published, one in 2011 and VMEC trial in 2022. So VMEC trial which was published in 2022 where primary endpoint was
2002
sorry 2002. So VMEC trial published first in 2002 with 489 patients. That was nesiritide, nitroglycerin and placebo, all were compared. The primary endpoint here was the good clinical status and better performance. But unfortunately this did not show any clinical significance. However, in large ASCENT trial that was published in 2011, 7,000 patients were studied. Primary endpoint was relief of dyspnea, but again it was not significant. Composite endpoint of death, re-hospitalization, everything was more or less similar. So based on this clinical trial in 2011, nesiritide was not recommended to be used in heart failure. So in 2013 and 15 the use was
against placebo છે એસેન્ટ કમ્પેરેટર શું છે એસેન્ટ
एसेंट में कंपैरेटर से नाइट्रोग्लिसरीन और प्लेसिबो आल्सो बोथ तो બંને માં સેમ જ છે પ્લેસિબો નાઇટ્રોગ્લિસરીન અને nesiritide. Then second drug came, that was serelaxin, recombinant human relaxin 2. It increases arterial compliance, cardiac output and renal blood flow. Initial data was promising, however, large trial which was published in 2019, Relax HF2, endpoint of mortality and worsening heart failure was not significant. None of them, composite endpoint, heart failure, mortality, none of them was significant. So this is also not advisable to use. So what we are left with vasodilator is only nitroglycerin as of today. Inotropes, the third drug. Noradrenaline, adrenaline, vasopressin is being used and it has proven their usefulness. Beyond that, we have mindrinol, phosphodiesterase inhibitor. Again, this was used very commonly in past. It's a type 3 phosphodiesterase inhibitor and it works by increasing cyclic AMP, having positive inotropic effect and additional vasodilatory effect. So, the problem with this, there was no significant change in hospitalization. If you look at this median and mean hospital days of hospitalization, p-value was not significant. So there was no change in hospitalization days or death or readmission. However, there was noticeable episode of treatment failure, sustained hypotension, acute MI also new occurrence of atrial fibrillation, and increase in mortality. So again, this drug is also not recommended to be used. Nowadays it is not being used. Omecamtiv mecarbil, more or less it acts by increasing stroke volume by increasing duration of systole, less side effects than traditional drugs. However, when tested in trial again, it did not show any change in endpoint. So again, this is also not to be used. So what we are left with in inotropes, again we are left with either adrenaline or adrenaline vasopressin. So more or less all
What
trials,
about dobutamine?
dobutamine is useful. Dopamine, dobutamine both are useful. And there's a trial that are positive trials. So whatever this newer drugs trial are almost negative trials, not even non-inferiority trial. There are negative trials. So whatever we are left with is only traditional drugs, diuretics, adrenaline, noradrenaline, dopamine, dobutamine, vasopressin.
Which drug you missed?
Sorry,
Which drug you missed?
in this vasopressors. Then I will nitroglycerin just to say nitroglycerin.
Inotropes से बात करी थी आपने. Most important drug with a very specific indication. That is levosimendan.
Levosimendan, yeah. Levosimendan. I actually missed in the presentation also.
Yeah, exactly. Where it is drug of choice?
No, I have not used that.
Takotsubo.
Okay. So device based therapy.
एक मिनट. हाँ सर.
અહીંયા યુઝ થાય છે
हाँ, available
हाँ
છે.
सर. वो
Available.
पहला तो वो यूज करी છે અત્યારે તો. हाँ आगे.
So that brings us to the device based therapy. Because majority of drugs, there are no new any development in last couple of decades. So device based therapy, again there are certain device, venous occlusion device. The basic funda of this device is to reduce cardiac volume overload. So either we can reduce cardiac volume overload by decreasing preload or decreasing afterload. Decreasing preload, we can either occlude SVC, we can occlude IVC and reduce preload to the heart. We can put some pump into SVC or IVC which can pump blood from the SVC to directly to pulmonary arteries. That can also reduce your cardiac volume. Or we can increase cardiac output by the means of IBP device or impeller device or some ventricular assist device. But that is not preferable in a like impeller or something is not available in our country. Majority of device is not available. Even if it is available, it is very costly. But just for the sake of discussion, one device is precardia, that is SVC occlusion device. In this, a balloon is implanted into the SVC by internal jugular vein, and this balloon electronically can get pulses intermittently, so that will reduce cardiac overload, cardiac volume overload, and it reduces CVP also, and it enhances renal blood flow. So that is intermittent SVC occlusion. The next device is intermittent IVC occlusion by reducing transluminal cable flow, and the basic mechanism of action of this device is biventricular interdependence reduction. So in heart failure, there is RV volume overload. LV is getting compressed by the RV volume overload to certain extent. If we can reduce his RV volume, the ventricle septum will get moved towards its normal position, that is expected to increase LV compliance and stroke volume, and that will reduce your congestion. So this is the basic funda. Second basic mechanism is it increases renal arteriovenous pressure or arteriovenous gradient. By reducing IVC and SVC flow, we will reduce the renal venous pressure, so that renal arteriovenous gradient will increase. That will lead to increased filtration of the blood, and that will lead to fluid reduction. So these are the two basic mechanism of action of these all devices. Either it may be SVC device, IVC device, or forward. So IVC device is Doroya catheter also. This device first used I think in 2017 for very small number of patients, 18 or 20 patients for 12 hours only, and that has improved decongestion. Now it is being currently evaluated on a larger basis on phase 3 trials. So this device is a small pump which is implanted into the IVC that reduces your cardiac congestion and improves your renal arteriovenous grade. Another device is Proprion aortics. This is implanted in aorta below the just above the level of the renal artery. It will improve your renal arterial blood flow. This is like an impeller. What impeller does? Impeller is being implanted into the left ventricle. It will unload the left ventricle. It will push the blood from the left ventricle into the aorta. Now the problem with impeller is we need to cross aortic valve. In certain patients, if aortic valve is having any calcification or any plaque formation, that can get disclosed and that can lead to stroke. So this kind of device, why it was being invented, we does not need to cross aortic valve. So the chances of stroke remains low. This is being implanted into the descending thoracic aorta or descending abdominal aorta. So this is easy way of implantation, no need to cross aortic valve. So this kind of device is being used. Similar descending aorta devices are right hand catheter pump, procedural aortic, second heart assist device, more or less all a similar mechanism of action that increases renal arterial flow, reduces afterload and increases cardiac output. Beyond this, now from here onwards, everything we know and everything we are practicing, guideline directed medical therapy. So in case of acute heart failure, when you crossed over the acute crisis of heart failure, then you need to start on guideline directed medical therapy. That will bring in the picture of all pillars. In 2013, there were three main pillars: ACE inhibitors, ARBs, beta blockers, and mineralocortical receptor antagonists. 2014, a paradigm HF trial was introduced, and that introduced ARNI, and that changed the face of heart failure treatment. This trial showed that ARNI reduces heart failure by nearly 20% reduction in the primary composite endpoint of CV death and heart failure hospitalization. Separately, cardiovascular death reduction was as high as 20%. Heart failure hospitalization reduction was by 21%. So this was being used since 2014 and everyone is seeing this is.
So see the beauty of the trial. Go back to this thing. So if you see the CV death, 16 versus 13, it's not even almost a 2%. Still they got a very significant p-value. How?
No, it's a early reduction. This trial was closed by premature. It was
Fully agree, but generally relative risk reduction of 2% may not translate into statistical significance, but still the p-value is less than 0.001. How?
Maybe numbers were very high in heart failure.
Exactly. So the numbers were high.
Numbers
Because it was so much powered as far as the number of patients are concerned, a very small reduction gave you a nice p-value.
and that led to early termination,
exactly.
premature termination.
So that's the beauty of trial.
Similar type of
But as we have seen in clinically
Clinically it is satisfiable, that is why it's good, but otherwise it can
only
be very
problem is hypotension and renal dysfunction.
there can be very big gamble following these things.
Captopril was another medicine which we have used.
Yes.
Having a very good result, but unfortunately,
Only thing now, some people are using valsartan still, where we cannot use ARNI, because ARNI had valsartan in it. So people
Many nephrons are using.
So in 2015, SGLT2 inhibitor was also introduced, and that also showed cardiorenal protection. And multiple trials of SGLT2 inhibitors were found to be positive, and there was nearly risk reduction by 30% reduction in heart failure hospitalization in multiple trials. So in 2014, the fantastic four pillars of heart failure were introduced. ACE inhibitors, ARBs was replaced by ARNI. If ARNI is not tolerated, ACE inhibitors, ARBs is always there. Beta blockers hold its position, MRA holds its position. Fourth new pillar introduction was SGLT2 inhibitor. So previously, before 2021, somewhere in 2020, it was said that we introduce everything by sequencing. Add one drug, wait for some time, add second, add third. Now there is rapid sequencing. If at all possible, add all four drugs simultaneously. If not, Add beta blocker SGLT2 inhibitor in early phase where BP is still settling. Once BP is in good control, diuresis is achieved. Either use ARB or ARNI followed by mineralocorticoid receptor antagonists. And this should be done very rapidly in within maybe 3 to 4 weeks of initiation of heart failure. And this also has been studied. When risk reduction and expected lifetime benefit of comprehensive disease modifying therapy, conventional versus comprehensive. So this reduced cardiovascular death and heart failure hospitalization by 62%, alone CV death reduction by 50%, heart failure hospitalization by 68, 47 all-cause mortality, and 44% projected event-free life survival was expected at the age of 55. So rapid sequencing has been tested. If at all there is no hypotension, you can still do rapid sequencing of all these drugs. This drug has been again studied in strong HF study, more or less similar result, all-cause mortality reduction by rapid sequencing. So while there has been considering success in the past 2 decades in heart failure therapies, there remain significant unmet needs. Beyond this 4 pillars, some drugs are also still remaining, that is newer drugs. And that brings us to the fabulous 5, that is Vericiguat, studied in Victoria trial. Victoria trial showed that the CV death does not have any major change. Heart failure hospitalization reduction is significant. Total heart failure hospitalization again significant. All-cause mortality reduction is significant. Composite endpoint of all the 3 is significant. So Vericiguat, to certain extent, when your heart failure 4 pillars are not active, you can still consider Vericiguat, although it is costly as of now, and it also has multiple side effects. So it's a novel drug which acts by activating cyclic GMP level in body, and this cyclic GMP leads to vasodilatation and by the means of smooth muscle vascular relaxation. And basically the funda here is endothelial crosstalk. The endothelium of peripheral artery has crosstalk with systemic endothelium and has crosstalk with the cardiac endothelium. So once you target any endothelium, either cardiac or systemic or peripheral, there will be increase of cyclic GMP all over throughout the body, and this will lead to relaxation of all smooth muscles, leads to reduction of congestion and improves cardiac. So based on this Victoria trial, the recommendation is ESC guidelines and ACCHA guidelines both. Vericiguat can be used in NYHA class 2 to class 4 who are having worsening heart failure despite all 4 pillars. ACCHA more or less said same. In patient with progression of heart failure with reduced ejection fraction despite guideline directed medical therapy, Vericiguat can be used. So this is used in heart failure with reduced ejection fraction. And when we look at in terms of reduction in anti-proBNP, Vericiguat did show reduction in anti-proBNP significantly as compared to the control. Control was less. Next therapy, flight of 6, is intravenous iron. I personally feel intravenous iron should be used before the Vericiguat, and Vericiguat should be the 6th one. So in guidelines wise, all patients with heart failure should be checked periodically for iron deficiency. Intravenous iron supplementation, maybe 3-4 steps.
9:35.
3-4 steps. Intravenous iron therapy in terms of ferric carboxymaltase should be given to all symptomatic heart failure patients who have iron deficiency. And erythropoietin stimulating agents is class 3. It's not recommended. So to summarize, more or less now it's a summary. So there are multiple drugs which was used for decongestion. Tolvaptan was used. Some rotophilin was also used, which was not significant. Furosemide or continuous injection of loop diuretics followed by acetazolamide and hydrochlorothiazide was also used. And then came the guideline directed medical therapy, that is sacubitril valsartan, SGLT2 inhibitor and beta blocker and MRS. So what should we do? Decongest early by the means of loop diuretics or sometimes acetazolamide also, and start guideline directed medical therapy as early as possible and up-titrate in rapid sequencing. If we don't do up-titrate, the steep curve is very steep of progression of heart failure. If at all we decongest early, GDMP started early, the curve flattens out. So that was all about heart failure. One more drug which I forget to discuss is Finrenon. Finrenon is a non-steroidal MRA. Recently started coming into the picture by pharmas. Even guidelines has also used this as a second pillar in patient with heart failure with mid-range or preserved ejection fraction. Unfortunately, we had only one SGLT2 inhibitor. Now Finrenon is being introduced as a second pillar. Again, similarly, in heart failure with preserved or mid-range ejection fraction, acute therapy is diuretics. After decongestion, guideline-directed medical therapy, which involves treatment of the underlying pathophysiology, may it be hypertension, may it be diabetes, may it be acute coronary syndrome, and followed by this pillars. Unfortunately, RNA does not have any significant role in preserved ejection fraction patients. So that was all about heart failure in nutshell. That was the review of heart failure.